I'm representing the Society of Behavioural Health Singapore, and I'm also faculty staff here at the Chian School of Medicine, NTU. It truly gives me a great pleasure to welcome you all today for a webinar series on COVID-19. These are organized by the Society of Behavioural Health Singapore with the support from Tote Health Board and LKC Medicine. The world, our world, has changed rapidly within a short period of time as a result of the COVID-19 pandemic. COVID-19 is afflicting in different ways all the countries on our planet and is affecting the lives of all of us. During these times, it is important to support, to connect, and to mobilize our actions. And the success of any directives or measures taken is very much dependent on our behaviors. Over the last few weeks, we have been hearing a lot about flattening the curve. But what is this and why is this so important? Furthermore, how can we do our best to support, to maintain healthy and resilient communities in these difficult times? Our expert speakers will share on these topics over this series. And to kickstart our webinars, I would like to invite for our opening webinar, Dr. Alex Cook, who will set the stage by discussing the topic of flattening the curve. Dr. Alex Cook is an associate professor at the Hock School of Public Health at the National University of Singapore. He is also the Vice Dean of Research and a leader in the Biostatistics and Modelling Domain. He holds joint appointments with Duke-NUS Medical School, the Department of Statistics in NUS, and the Communicable Disease Center at Tan Hospital. Dr. Cook leads a multidisciplinary team of researchers from the fields of mathematics, statistics, computational biology, computer engineering, and environmental sciences to study and model disease. He has worked extensively on disease modeling in the context of infectious diseases, including seasonal and pandemic influenza, TB, dengue, and foot and mouth disease. His work is widely cited, both scientifically as well as the local and international media, and his work has contributed and guided a lot of our national healthcare policies. So, Alex, thank you very much, and on to you.
Well, thank you very much for the introduction. I feel a little bit shy now after that intro. So I'm very honored that you've all chosen to give up part of your Saturday morning to listen to me talking. It's a rare situation in which mathematical modeling has attracted so much media attention. And you know, a week ago, one of the professors of mathematical modeling in London got infected with COVID, and that was like headline news in the UK. So I think that shows kind of the current excitement around about the use of mathematical modeling. So I'm going to, in this talk, I'm going to very briefly just give you a little bit of background about what this whole idea of mathematical modeling of infectious diseases is, because that is quite important in order to understand how it is being used to support the decision-making that policymakers are doing just now. So mathematical modeling for infectious diseases is not a new thing. You go back in time, over 100 years, you've got this paper here by Ronald Ross, who won the Nobel Prize in Medicine for discovering one of the vectors of malaria. But he also is polymath. He was able to do a lot of research in mathematical modeling of malaria and other diseases. And so you can see in this paragraph 2 of his paper in BMJ in 1915, he lists out a mathematical model which is actually not too different from the kind of models that we're using just now during the COVID outbreak. So I'm not going to give you a lot of equations in this talk, so I realize this is not a mathematical audience. But I think it's important to realize that these equations represent a way of understanding the world in a simplistic form, but yet in quite a realistic form. So if you take the kinds of models that people are building for outbreaks like COVID, and you run those models forward in time on a computer, then you find that actually the dynamics that emerge out of the model represents qualitatively what we see in most infectious disease outbreaks. So typically, there will be an early period of the outbreak, a phase of exponential growth, And then after a while, you have a peak in the epidemic and it starts to come back down again. It looks overall a bit like a normal distribution. And a very large number of the epidemics that we see in real life concord with what the mathematical models show. So just to give a little bit of evidence to support that, I've extracted out maybe about a week ago, the graph's a little bit out of date, the number of cases in different countries that have been affected by the COVID outbreak so far, in particular looking at the countries which have been most affected. And I'm plotting the number of cases on a logarithmic scale here. So instead of seeing an exponential function, you see a linear function, right? So after they get to some size, they all behave in the same way and they all behave like an exponential growth, which is what the mathematical models show. So the first of the questions that I want to try to address in this talk is to understand one of the most fundamental concepts in mathematical models, which is about the reproduction number and how transmissible a virus is. So I want you to imagine that you are, in fact, let's say we go back in time to January, we're not doing much to try and control the outbreak, and that you're infected by a virus, let's say it's the COVID virus, the SARS coronavirus 2. So how many people will you infect? Well, let's say that we'll assume that you know n people in your social network, and you come into contact with a proportion C of them. And then for each person you come into contact with, there's a probability V of virus transmission. And every time you try to infect someone, the probability that the host gets infected is, I can't see what I put there, was a H maybe something. Sorry, my video is now kind of like over the screen, I can't see it. So if that's the case, how many people are you going to infect on average? Okay, well, the number of people you know, the proportion of them you come into contact with, the proportion that you transmit the virus to, and the proportion who get infected, right? So n times c times v times h. So this is what we call the reproduction number. You multiply these things together and it tells you how many people on average you will infect over the period that you are infectious for. This is the fundamental constant that we use to quantify how transmissible a virus is in a population. And the reason I've decomposed it up into these terms and colored them is to show that the things that go into this is a mixture of both social and biological factors. Difficult for us to control the virus. We can't really change its dynamics within the body, etc. But what we can change is the social factors. So how many people you're coming into contact with, for example. If you can reduce that by a half, then the reproduction number will go down by a half. So I'll ask a very quick quiz. I've got 3 viruses up on the screen there. How transmissible are these 3 viruses? Ebola, measles, and Zika. Okay, so let me tell you. So of the 3, measles is by far the most transmissible, followed by Zika, followed by Ebola. So people have quantified the reproduction number for these in some other settings. So for measles, it's close to 20. For Zika, I still can't see what the number is. Oh gosh. Let me see if I get rid of my own video here. No, I can't. Okay. For Zika, it's about 2, and for Ebola, it's probably about 1.5. Which of the viruses would you rather get infected by? I think most people would rather not get Ebola, would rather get measles or Zika. So it's important to distinguish between transmissibility and severity, right? So the transmissibility will determine the frequency that the disease will appear in the population, but the severity of the disease interacts with that to get the overall impact of an outbreak on a population. Now, the reproduction number actually is a very important threshold because it determines whether we're able to control an outbreak or not. If reproduction number is 2, as it is for Zika and as probably is for COVID, then you end up with a doubling every generation in the number of new infections. That's why you see an exponential growth. If the reproduction number were down to a half, you start off with 10 cases, next generation you got 5, then you got 2, then you got 1, then you got none. Okay, and so you end up with an epidemic which is declining in size. You don't need to worry about it. If the reproduction number is 1, that is the threshold at which each generation is the same size as the next. So the population from the virus perspective is maintaining itself. Okay. So reproduction number of 1, that's the threshold that we need to get it below in order to control an outbreak. Now, the reproduction number also determines how big an outbreak is going to be. I'm plotting here another way to think of that infection tree. So each generation is a part in the x-axis, and I've colored one of them in blue. So I'm going to give you a little story about why that. is. So let's imagine that I'm one of the cases in generation 3. So I infect 2 people on average. They happen to be my wife and my younger boy. The younger boy infects his teacher and his mum, but his mum is my wife and she's already been infected. And so over time, the virus, although it is being transmitted to individuals, let's say to 2 individuals on average, but some of those individuals have been infected already and they will not get it. And that is why not everyone will be infected during the current COVID outbreak, right? Because at some point, they will be protected by herd immunity. So the reproduction number tells us about the potential transmissibility at the start of an outbreak. But this then gets moderated down as the population starts to become infected and then progresses through to being immune to it. Okay. Now, if you take these mathematical models, let's take the viruses I showed you before, and you run them forward in time, you see how many people get affected over the course of an outbreak or a first wave of an outbreak. Then we can actually plot those. I'm cheating a little bit because I couldn't fit measles onto the screen, so I made it 5 just for the purposes of the graph. Now, it looks like they kind of follow some kind of a curve there, and actually mathematicians have worked out that there is an equation which characterizes that curve, okay, and it works for all kinds of diseases. And importantly, it's a relatively simple equation. It's one equation, it's got 2 unknowns, but if you know the reproduction number, you can solve the equation. You can say then how big the outbreak is going to be as soon as you can estimate what the reproduction number is. Okay, so that's important because at the beginning of an outbreak, we have a good idea of what the reproduction number is, and we can use that to try to then project forward to see how many people will be infected. It's also important because it tells us what we need to do in order to bring down the final attack size. So we can change the reproduction number by implementing social distancing, so impacting on the social component of the reproduction number. Sometimes exogenous factors like the environment may come in, so like in seasonal countries, influenza rises in the winter and it falls in the summer. And then of course, the reproduction number is moderated by herd immunity over time. So imagine if you were able to bring down the reproduction number by 1/3 by implementing social distancing, which knocks out 1/3 of the contacts that you have. Well, how much is that going to impact on each of these 3 viruses I showed you? For measles, it will have almost no impact because it's so transmissible. Even if you knock down 1/3 of the infection, 1/3 of the transmissions, you're still going to end up with almost everyone getting infected. With Zika, you end up going from about 80% to around about 50%. That's a big decline. But an important thing happens with Ebola. So if you look at Ebola, we've gone from 60% of the population getting infected if you do nothing to having no one getting infected. So effectively, the outbreak just crashes. And so that is what the target is going to be for controlling the COVID outbreak. Can we bring down the reproduction number enough that we are able to crash that outbreak? And it turns out that what we need to do is to bring the reproduction number down by 1/2 if the reproduction number is 2. So we need to knock down our contacts by around about 1/2. And so that leads on to the strategies that have been evaluated by many groups, including myself. But I'm going to talk a little bit about the Imperial College modeling projections because they've been in the news, international news, quite a lot over the last couple of weeks. And so they've been talking about the idea of how we can try to flatten the curve. And over the next 1 minute, I'm going to try to explain this briefly. So I've extracted out the main graph from their paper. So they're showing there in black that what happens if the government does nothing and just lets the epidemic run its course. So at some point, you will end up with no more infections because so many people have been infected already that it's not able to transmit further. And so in their model, they look at different kinds of policies and see what the impact is going to be in terms of the overall epidemic dynamics. So for example, if you close schools for the duration of the grey box, then you would anticipate that the number of infections should go down and the outbreak would be pushed back a little bit. But the number of infections have not gone down by a lot because the impact of closing schools is relatively small in an overall population because actually kids are not having a huge role in the transmission of this particular virus. They've looked at what happens if you have isolation of cases, if you have isolation and quarantine of household members, or if you have isolation, quarantine, and then social distancing amongst the elderly. And these are all, as you put more and more interventions on, you bring down the overall size of the outbreak, you push it back in time, and you reduce the total number of infections. Now, it's not very thrilling, is it? Because you're hoping that you can get it down to zero. And so it looks as if maybe having the latter policy of isolation, quarantine, and social distancing, it may not have enough of an impact. But actually, the whole point of this is not just to try to bring down the total number of infections, it's to try to bring down the instantaneous number of infections. Because what we're seeing in a lot of countries, like Wuhan originally, Italy, and Spain now, is that when deaths are happening, it is when you go above some capacity that the healthcare system has in order to look after those patients. So when you have enough ICU beds for all the people who need an ICU bed, then the mortality is kept to a relatively low level, right? So if you can stay below this red curve, then you will get deaths, but you won't have that many. However, when you go above the red curve, you have people who are requiring intensive care in ICU ward, but are not able to get it because there's not enough beds for them. Okay, so the idea of the flattening the curve strategy is to try to push the epidemic, drag it out for as long as possible by making it at a low level, such that the amount of patients who require ICU over the entire duration of the outbreak is kept as low as possible at any instant in time, so that there's enough beds for them. Okay, so this, as you can see, the strategies that the Imperial Group have been proposing are not enough to prevent you breaching the number of ICU beds. And that is why it's important to consider more extreme scenarios, such as a complete lockdown, which is what some other countries are implementing. In Singapore, I think that we're now still comfortably below that red line, but at some point, if we are not able to control the outbreak anymore, then we'll get close to the red line. And I would anticipate that when that happens, then the current ratcheting up that we're seeing in terms of our interventions will be ratcheted up further in order to try to just keep as long as possible below that red line. Okay, so I think I've slightly overshot my time, so I'll stop talking now and I'll hand over back to the chair. Thank you very much for your attention.
Great. Alex, thank you very much. We do have a number of questions that have been posted by our audience and ourselves. So you talked quite a bit about the reproduction number, and we wanted to ask you, in attempting to flatten the curve, how important is the reproduction number in considering the type and the extent of the measures that should be considered or implemented? So ranging from social distancing measures to more complete lockdown, as we've seen in the different settings.
Okay, so it is vitally important. Because if you consider two scenarios, imagine if the reproduction number is 3 or if the reproduction number is 2, then the amount of effort that you would need to put into controlling the first of those two scenarios would be substantially more. You'd have an epidemic growing much faster, and you'd have to do a lot more in order to try to control that. Now, at present, it seems as if the reproduction number in Singapore is being kept to around about 1 by the efforts of MOH, so the contact tracing teams, and then also the policies around about isolation and quarantine, which seem to be implemented in a much stronger way than a lot of the European countries, which are now facing really severe outbreaks.
Great. Thank you. And I was about to ask, what's the estimation for the current reproduction number for COVID-19? So I just wanted to ask in relation to this, often we use data from different countries in order for us to make the projections around disease modeling. And I wanted to ask you, what are the advantages or potential disadvantages of adapting those parameters and trying to make decisions in developing local epidemic models and projections?
Yeah, that's a very good question. It's a difficult one to answer. Obviously, in the early phase of a local outbreak, then you don't have data from the local place that you're trying to analyze for, right? So way back in January, all that we had was what was coming out of Wuhan. And so the models that we developed earlier on were based purely on information that's coming out of China. As more and more cases accrue locally, then we have the ability to tailor the models to the local context. But it has been, I would say it's difficult to do that because actually we've been controlling the outbreak too well in Singapore from the perspective of trying to build models of it. And so it's been very difficult to try to build models which adequately characterize things when control is being implemented so strong, but also where the change in policies over time is having quite a big impact on the overall numbers of cases. So for example, we've seen a big rise over the last 1 or 2 weeks. And this is actually mostly due to returning Singaporeans who are fleeing Europe. So in a way that is something which is almost exogenous to our own setting. We've got an outbreak in Europe which is going crazy, but if we build a model of Singapore, then the model naturally does not account for a number of cases in Europe, like in Italy or Spain. And so that's one of the challenges to trying to build a model which will adequately characterize the local outbreak, is that you have all these little fancy things that come in that you're not anticipating, although in retrospect, you think, well, why did I not think that Singaporeans would run away from Europe when the outbreak is bad there?
Okay, thank you. And back on the reproduction number, do we have any rough estimates? What was it in the initial stages when we first had the cases with COVID-19, and what are some of the current estimations of the reproduction number in Singapore at this point in time?
Okay, so our estimates of reproduction number that we've been developing with MOH have almost never gone above 1. So because so many of our infections have been imported, initially from the first wave was tourists coming from China. Then more recently, it's been evacuees from the UK and US in particular. And so when we see the number of cases rising, actually for the most part, it has been due to things which are kind of like beyond, I would say, Singapore government control. However, I mean, there has been over the last few days, I would say, more and more unlinked cases, and this is potentially reflective of community transmission that we're not adequately controlling. So those unlinked cases eventually, because the many contact tracing teams MOH have, eventually we're able to draw out the links between those and then start to quarantine their contacts, and then that will have the impact of reducing secondary or tertiary transmission from them. Yes, your original question was, what is the number? It has been below 1 for most of the outbreak.
Okay, that's certainly quite encouraging to hear. There's been some that argue that perhaps the modeling presented by Imperial is somewhat pessimistic, and some of the analysis that come from the Princess Cruise perhaps saw a less gloomy picture. Therefore, there's been a bit of apprehension as to whether, the extent of measures is justified, particularly in the context of the economic implications and the economic gloom. What are your thoughts about this?
Yeah, so I'm very sympathetic to the arguments about the impact on the economy. I mean, I'm from Europe myself, so I mean, we've seen the big austerity programs that have been conducted across many European countries, and they have led to many deaths due to people not being able to get access to hospitalization, etc., that they needed. So I'm very sympathetic to that, the potential risk to the economy. Now, the question was also about whether the Imperial estimates are pessimistic. I think that now is probably the time to be pessimistic. There's an asymmetry to making mistakes here. If you think the epidemic is going to be quite bad and you prepare for it to be really bad, and it turns out to be less bad than you thought, then you're like, oh, that was lucky, good thing we prepared for it. If it's the other way around, where you think it's probably going to be okay, and then it turns out that it's not, then that's when you're going to really regret it afterwards. And I think that is the situation that actually many of the European governments were in earlier in the outbreak, where they thought that actually maybe not so bad, we don't need to prepare so much for it, we don't need to stockpile our PPEs, etc. And I mean, the death toll in Spain and Italy is really ghoulish just now. So I think that now is the time to be pessimistic and plan for the worst.
Thank you. I mean, given the data that comes from Europe, Italy, and Spain in particular, I think it's very wise to err with the side of extreme caution on this. I just wanted to ask, say if our social distancing, isolation policies are successful, and at some point in time the restrictions are lifted, what do you think is the risk of a second wave of infections, and what possible steps can be taken to avoid a second wave of infections?
Yeah, that's a very good question. It's something I should have spoken about in the talk. So suppose that, I'm going to draw a little picture here. So suppose that this is your anticipated epidemic, right? If you don't do anything at all to control it, but that you implement some kind of form of control at the time that I've drawn that line there. I hope you can see it okay. So what would happen then is that your control would then lead to the outbreak seemingly coming under control and going down to very low levels, okay? However, you have to realize that that is an unnatural form of control in that the population has not reached the level of herd immunity to prevent a second wave. And so what would happen is if you stop the control at that point, then you're going to end up with an outbreak that would, in magnitude, would be pretty much the same as what the original outbreak would have looked like, okay? So, actually the idea of flattening the curve is that we would be quite happy with this kind of a bimodal outbreak if we're at all time points below the threshold that we can handle in the health system. I'm sorry, that's a very amateur way of trying to illustrate the point. I think that the big question that I have just now is actually what's going to be happening next in China, because they have now successfully brought down their first wave down to close to zero. But the population in China seemingly is still mostly susceptible to getting infected. And so as they go back to work, if there are some residual pockets of infection, then they might potentially balloon up and you end up with another outbreak which is as bad as the first one. I hope that answers your question. I'm not sure, the screen has frozen. I'm not sure if I'm still online. Hello, can you hear me?
Yes, I think you're back live.
Okay, good.
I'm afraid we missed the last part of your answer around when you were discussing what we expect that will happen in China now and the second wave of infections.
Okay, sorry, may have been the NUS Wi-Fi. The big question is what will happen next in China. They brought down the first wave to close to zero, but we could still have an outbreak beyond that. I understand from the comments that apart from you, everyone heard me. So it's just at the central office there. So it's not my Wi-Fi, it's your Wi-Fi.
Yes.
Okay, yeah. Okay, any other questions?
I think, let me just have a look. Maybe one last question that was posted. The last question, are there any models to compare the socioeconomic impact of COVID-19 and perhaps flattening the curve versus letting the disease run its course?
Yeah, it's a very difficult question to answer. I'm not sure if I'm sure there's a lot of people out there working on everything to do with COVID just now. So I'm sure there's some really smart economists who are looking at it. I'm not aware of those models. I'm sure that the impact is going to be very severe, but I don't think that we can wait to see the output of those models before making a decision about what implementation we're going to do. And we know from things like, the SARS outbreak, the original SARS-1 outbreak, that, I mean, there was quite a big impact in the economy that year, maybe 1 or 2% off our GDP. I suspect that this time round it will be quite a lot bigger than that. But I think it'd be very difficult to try to have that trade-off between what is because there's an economic impact, obviously, to people dying. But if you can reduce that at the expense of shutting down the economy for a longer period of time, which of those trade-offs is worth it? It's not clear to me at all.
Great. Alex, thank you very much on behalf of the Society of Behavioral Health Singapore and our colleagues that are watching abroad. We'd like to thank you again for your time.
Okay, thank you very much.
Thank you.
Thank you.